Think forward. Think Research Channel.
The National Institutes of Health Clinical Center in Bethesda, Maryland is America's clinical research hospital. Training clinical researchers and building an international infrastructure of educational programs are top priorities. Welcome to our program.
Thank you. So I went to a cocktail party several years ago and didn't know anyone except the host. And so naturally when I walked into the party, I gravitated over to the group in which the host was standing, struck up a conversation. And little by little, the group drifted away, so I was left standing speaking with one of the women in the group. And she said, I have this joke, it'll just kill you. It is so funny. It's about this doctor, you see. And I said, wait, before you go any further, to avoid embarrassment, I better point out that I happen to be a physician. And she said, now don't you worry, I'll speak very slowly. And the reason I bring up that story is that some of the concepts that I'm about to cover today are very foreign to physicians. They're trained to think of cancer in a different way and medical screening tests in a different way. And sometimes it's the people who haven't been thinking about cancer screening tests their entire career that can grasp these concepts even more easily than the health professions. Now, I'm going to start off with a particularly counterintuitive observation that was in the news yesterday. It was reported in yesterday's New York Times, in which investigators at Dartmouth had, albeit indirect evidence that at least some breast cancers can regress spontaneously, particularly the ones that are detected by screening. And that's highly counterintuitive and therefore hit the news in a big way. But that is a totally foreign concept to most of the practicing health professions. And you'll see throughout this talk, the theme that there are a lot of counterintuitive observations connected with cancer screening in general, but also medical screening more generally. But I don't want to leave you with the impression that cancer screening is worthless. There are some worthless tests, and there are some worthless tests that have a net harm and are in common usage probably, but there are some beneficial tests. And you have to judge cancer screening tests test by test. Some have a net benefit, some it's too close to call, and some probably, or some definitely have a net harm. But some of them have a net public health benefit, and I want you to know that. You're going to perhaps walk away with a skeptical feeling, but I don't want you to walk away with a cynical feeling. And that's why in the back of the room there's a table that looks like this, and it has a variety of recommendations for commonly used screening tests for cancer. And you'll see that there are 3 different organizations in the columns, and they have somewhat different recommendations, and that's because there is some controversy surrounding some of the finer points, even of the screening tests that are out there now. But this is sort of the take-home. I don't want you to walk away with the impression that people shouldn't get any cancer screening tests, and you can take that home with you. So the title of the talk is The Clash of Medical Science and Intuition. And the reason I call it that is that screening for cancer seems to be so powerfully intuitive. Everyone seems to assume that if you can pick up cancer earlier than you would have waiting for symptoms, then it must be a good thing for the patient. It's not always true. Even though some cancer screening tests have a net benefit and some have a net harm and some too close to call, they all have some associated harm. It's just that the beneficial tests, the ones with a net benefit, have more benefit than harm, and you have to know about the harms, especially as a healthy person. It's difficult to make a healthy person better off than they already are, and that is the bar that screening for cancer has to meet, has to clear. Disclosures and disclaimers. I have no financial conflicts, no consulting or speaker honorarius, stocks, patents, or patent applications related to this subject or any other subject that I'm aware of. As an outside activity, an approved outside activity, I'm editor-in-chief of the Journal of the National Cancer Institute, JNCI, but oddly enough, the JNCI has no connection whatsoever with the National Cancer Institute or with the federal government, and the opinions you'll hear are mine and not official positions of the federal government or of the National Institutes of Health. One of my favorite quotes about this whole field is from Daniel Wopal, who said, in the field of cancer screening, it is particularly important to be able to sort out what is known versus what makes sense. Sometimes just too much seems to make sense, and we take mental leaps of logic even when we don't have all the facts in place. So I'm going to start. I said the field is highly counterintuitive, so I'm going to start off with a couple of brain teasers that on the surface appear to be counterintuitive. The first is the disparate trends in U.S. life expectancy versus healthy life expectancy. So life expectancy has been going up in the United States. That's the middle column, life expectancy in years. And it has been going up for quite some time. These last two periods are the last two reported for the United States. And you can see that life expectancy for the last two reporting periods went from 76.8 years to 77.2 years for a net increase of 0.4 years of life expectancy for the average American. But in the last column on your right-hand side is healthy life expectancy in years. And you see that gives a different pattern. The healthy life expectancy has gone from 48.7 years to 47.5 years for a net loss of 1.2 years. And so this brings up the sort of brain teaser. How can we possibly be getting healthier and sicker at the very same time in the United States? So this is not a mystery for those of you who have read a book by Norton Hadler called The Last Well Person. And the reason he calls the book The Last Well Person is he is taking the title of a commentary that appeared in the mid-1990s in the New England Journal of Medicine, in which an attending physician said that he was on rounds and he asked his house officers, what is the definition of a well person? And the medical resident answered without hesitating, a well person is someone who has been worked up insufficiently. And as we get more and more medical tests, we can make more and more healthy people sick by giving them a label. We either say that they have hypertension or they have prehypertension. They have diabetes or they have prediabetes. They have heart disease or they have coronary artery calcifications, which suggests they're on the verge. And so there are many, many tests that are progressively more sensitive in which we have the opportunity to label people with diseases that they never would have known they had. Another brain teaser is a quote from a prominent physician, Dr. Bloodgood at Johns Hopkins, who declared that the elimination of cancer was almost sure in its early stages. And what was his strategy for eliminating cancer? He said, and this is the quote, deaths from cancer would be practically eliminated if persons afflicted sought medical aid immediately upon the discovery of a foreign growth in any part of the body. And this is nothing more than a very crude cancer screening test. But this is the dawn of enthusiasm for widespread screening for cancer, because you can imagine the big splash that this made. And as a matter of fact, it was reported in the New York Times that this was the case. They could conquer cancer. The only problem is it was reported more than 3/4 of a century ago. And so now we know in retrospect how far off the mark he was and how misled Dr. Bloodgood was by his own personal observations. And how could that be? Someone who was so astute in clinical medicine, using his own observations, was so far off the mark. Well, I believe that he was misled. He was confusing the concept of survival with the concept of cancer mortality. He said we could eliminate cancer death, but the only thing that he could see in his own practice would be how long people lived after the diagnosis of cancer. And you can see a relatively crude test can advance the date of diagnosis of cancer. And so even if the person died of the same day, that is, had the same risk of dying, they carry the label of cancer for a longer period of time. Their survival from the date of diagnosis was longer. So that's an important theme for tonight's talk, and that is survival and mortality are not the same thing. On the surface, the terms sound the same. That is, survival means you're alive, mortality means you're dead, but it's not simply the obverse of the same coin. They are two different statistics. If they were the same statistic, then if you plotted changes in survival versus changes in mortality, so absolute increase in survival is plotted on the y-axis, the vertical axis, and changes in mortality in the United States over the same period are plotted on the x-axis, the horizontal axis, they would all line up. As one changed, the other would change. Well, this is the actual data in the United States. And you can see the points are scattered all over the place, and there's no association whatsoever between changes in cancer incidence and changes in cancer mortality over the period 1950 to 1996. And we know that there is no association because in the lower right-hand corner for the benefit of statisticians, and I know there's at least one statistician in the audience, the Pearson R is 0.00. So translated into English, that means it doesn't get any worse than that. So if I were to give you information about a trend in incidence, I've given you essentially no information about the trend in mortality, as counterintuitive as that seems. But it's so counterintuitive that people who are strong proponents of screening sometimes can get away with telling a reporter, a journalist, that with this new test, we've noticed that cancer survival has improved. It's gone from 5 years to 10 years, or from 3 years to 8 years, whatever. And then stop there, even though they have given the reporter no information whatsoever about what the impact of that test would be on cancer mortality. But it's so intuitive that the reporter can be lulled into thinking they have just gotten very important information about mortality. This is a picture of an iceberg. And I'm about to tell you the story about the Titanic as relates to icebergs. I have to, as another disclaimer, tell you that every single fact that I know about the Titanic, the ship Titanic, I derived or pieced together from watching the movie titled The Titanic. But my recall from that movie was that on its maiden trip, the Titanic was moving too fast. They had overestimated the capabilities of the Titanic when suddenly they saw the tip of an iceberg. And so they notified the captain and at the last moment started to steer the ship away from the iceberg. And at first, they thought they had averted disaster. But what had happened was the hull of the ship had scraped against the iceberg, which was beneath the surface and not visible to them. And that was what brought the Titanic down, hitting what was buried beneath the water level, what was not visible. And the reason I bring that up is that's exactly the case for cancer screening. It is not the tip of the iceberg. It is the bulk of the iceberg that's invisible that brings the ship of cancer screening down, or some cancer screening tests. So let's look at a cartoon of an iceberg. This happens to be breast cancer. So you see the figurative iceberg and the tip of the iceberg. Almost everything that we have known through the ages of medicine and description of cases of breast cancer was derived from observations, well-documented observations, of women who suffered and were diagnosed because of the symptoms of breast cancer. We didn't have any diagnostic tests or screening tests to pick it up. So the natural history was derived from the tip of the iceberg above that water level. But there were many cases of cancer that were silent and beneath the water level, so that as mammography came along, you could dip a little bit lower into that iceberg, and then as more and more sensitive tests came along, For example, MRI, which has been in the news lately as a screening test for breast cancer, you could go well below the water level and pick up many, many more lesions that you never would have known about. And the problem is, we don't know what the natural history of those lesions is. Why not? Because we've never ever observed them. Once we detect them, we feel our hand is forced. No one feels comfortable enough watching a breast cancer without treating it. And so we don't know the natural history of what these increasingly sensitive screening tests can pick up. But we know that because of the shape of the iceberg, there are many, many of those lesions. And so our hand is forced, we treat them, but we have to accept that there's a possibility of overtreatment. That is, we're treating lesions that never would have come to medical attention had it not been for increasingly sensitive tests. This is the situation of the iceberg in prostate cancer. So I've labeled this the prostate cancer pseudoepidemic in the United States for reasons that you will see. The horizontal line near the middle of that slide shows the rate of prostate cancer that we would have in the United States now if the rate were exactly the same as it were in 1973 when we started collecting statistics through the National Cancer Institute SEER database. So that is the flat baseline, but that's not what happened. Over the quarter of a century from 1975 to 2000, there was first a slow increase in prostate cancer incidence, followed by a very rapid increase. The slow increase was most likely attributable to transurethral resections of the prostate, TURP or TURPs, which is a more or less like a roto-rooter operation through the penis to clear out the urethra and relieve the pressure from the prostate gland, which can be pressing on the urethra and obstructing urinary flow. But in the late 1980s, a new test came along that came into common usage for screening, the PSA blood test. And many men started getting screened for prostate cancer, as you're undoubtedly aware, and you can see what happened. A pseudo-epidemic was suddenly created with the most rapid rise of any cancer in our history of collection of data on cancers in the United States. And then it peaked in the early 1990s and it has started to come down. So in essence, because of that, over 1 million men who would not have been diagnosed in 1973 have been diagnosed. As a matter of fact, the estimates these days come closer to 2 million men, but over 1 million men that never would have been diagnosed, as far as we can tell, were diagnosed as a result of a screening test, which isn't all that sensitive. And now let's compare that to the death rate from prostate cancer. And you got a little different picture. It's similar, but obviously the swings are not nearly as wide. And you can see that as the incidence of prostate cancer was climbing, so was the mortality of prostate cancer climbing a little bit. And then as the incidence started to drop, the mortality of prostate cancer started to drop a little bit. But it's a much flatter curve over the same quarter century compared to the wilder swings of the numbers of new cases or the incidence of prostate cancer. So it's easy to see what would happen to, you already see that the mortality rate didn't change very much. It's been going down lately. At least we know some of that is due to better treatments because there are randomized clinical trials that show improvements in outcomes in men who have even relatively advanced prostate cancers. We hope that some of that is due to screening, but we don't know that, and there are ongoing trials that John Gallen mentioned that will prove the worth or harm of prostate cancer screening, but they haven't reported their results yet. But you can tell that even though the mortality rate has been relatively stable, the survival rate had to have gone up a lot because there are many, many more cases, but about the same number of deaths. Likewise, the cure rate went up dramatically. Many, many more cases, and yet about the same number of men are dying. And so not only does the survival rate go up, the cure rate goes up even when mortality may not be changing very much at all. And that's an important take-home point. As a matter of fact, in the United States, we have one of the highest rates in the world of prostate cancer incidence. We have about the best survival rate of prostate cancer in the world. Our 5-year survival rates are in excess of 98%. They're around 99%. Makes you wonder why they even call it cancer anymore, as a matter of fact, because many, many benign diseases are more lethal killers than that. But our mortality rate is still one of the very highest in the world and remains one of the highest in the world. So the early detection mission, therefore, in cancer screening is not to pick up as many cancers as you possibly can. And it's not even to pick up as many early stage cancers as you possibly can. It's to reduce cancer mortality, or failing that, at the very least, to reduce cancer morbidity. The problem is most of our tests can't meet the second bar, that is reducing cancer morbidity. And why is that? It's because the morbidity of treatment for most cancers is quite impressive. We do major surgery. Cancer surgery is often a very big operation. We give radiation, a known carcinogen to human beings, and we give chemotherapy, often, again, a known carcinogen to human beings. So it's a high bar to clear. As I mentioned before, it's tough to make a healthy person better off than they already are, and especially if you are going to make a diagnosis in an asymptomatic person of a silent cancer and then start using major surgery, radiation, and chemotherapy. Now, what fools us into thinking that tests that even have a net harm look like they are good? What fooled Dr. Bloodgood of Johns Hopkins University? Well, the three well-known biases that go by the names selection bias, lead time bias, and length bias. Selection bias occurs because when you issue an invitation to the public to come in for a screening test, not everyone comes in for the screening test. They self-select. Some people pay attention to the health messages, and some people don't. And the ones that pay attention to the health messages are often fundamentally different in important ways from the people who don't pay attention to the health messages. So remembering, people who pay attention to health messages are getting them from radio, television, they're scanning the internet, they're dealing with health chat rooms, and they're trying to get as many hints as they can how to keep healthy. They have a different diet, they tend to exercise a lot more, they don't smoke, and so their underlying health is better anyway, even if they hadn't come in for the screening test. They also tend to be wealthy, they tend to be drawn from the majority white population. They have health insurance, and they can go wherever they want when they get their diagnosis. And so they may have done well, irrespective of whether or not they actually had the screening test. We've documented the healthy volunteer effect in the trial that John mentioned, called the PLCO trial, prostate, lung, colorectal, and ovarian cancer. That's the PLCO. This is a randomized trial in which men are randomly assigned to be screened for prostate, lung, and colorectal cancer or not, and women are randomly assigned to be screened for lung cancer, colorectal cancer, and ovarian cancer or not. The or not are the control groups. And so we had the opportunity to look at the population of volunteers who agreed to come in for the trial, were interested in screening in the trial, and came in for random assignment to the screening arm or the control arm. And we had and that's the PLCO percent column that you're going to see, men and women. And on the right-hand side of the slide, we could compare the people who volunteered for the trial with the average American health, that is the National Health Interview Survey, again, men and women. So you can see that the people who came in who are interested in participating in the screening trial had a very low rate of smoking compared to the national average. They also engaged in much more physical activity compared to the national average. They were a much more educated group and therefore presumably more wealthy than the national average. And they had fewer underlying medical problems that are health and life-threatening. So it was generally a healthy volunteer effect. And so you wouldn't be surprised that they would have a lower risk of dying of almost anything. Now, we have not reported the mortality from the actual PLCO cancers. That is being shown, that data is known only to the Data and Safety Monitoring Board, which independently looks at the data, independent of the investigators. But we do have access to other causes of death in the PLCO trial. And again, we can compare it to expected numbers of death. So to get the standardized mortality ratio, you take the number of deaths that were observed in your population and divide it by the number of deaths that you expect in the same age population, or the average population, in the United States. And so, for example, if you have 100 deaths in the trial and 100 deaths expected, then you get a standardized mortality ratio of 100 when expressed as a percentage. The numerator and the denominator are equal. But the standardized mortality ratio will be under 100% if you see fewer deaths in the study than you expected. So let's take the first line. If you look at all non-PLCO causes of death, the standardized mortality ratio is 43. That means only 43% of the expected deaths were observed in this group. They're very healthy. And then you go down the whole list. If you look at all these life-threatening diseases, there is a far lower risk of dying of any of those diseases for participants who volunteered to join the PLCO trial compared to average age-matched Americans. And obviously, this shouldn't be unless they had better underlying health, because we weren't screening for any of these diseases. So this is irrespective, completely independent of the screening that they were getting in the course of the trial. So that was healthy volunteer bias or selection bias. Now on to lead time bias. I alluded to this earlier. Lead time bias occurs because whenever you have a screening test, it will advance the date of diagnosis. Otherwise, it's not even called a screening test. And in so doing, you introduce lead time bias, since we usually measure survival from the date of diagnosis to the date of death. And so someone whose date of diagnosis has been advanced by the screening test has an unfair advantage. That is, you start counting their survival earlier. And so they have a guaranteed extra survival time, which is equal to the lead time bias. So let me talk to you about a theoretical cancer. I have in my mind a cancer that always kills its victims on the 4th anniversary of its diagnosis under usual circumstances. 100% of the time, it kills its victim on the 4th anniversary. So obviously, the 5-year survival rate for that cancer is 0. Now you develop a new cancer screening test that does nothing more, doesn't change the date of death, does nothing more than advance the date of diagnosis by 3 years. So now what happens if you look at the 5-year survival rate? The 5-year survival rate is 100%. So you haven't saved a single life because the predicate is everyone died on the same day. It's just that the 5-year survival rate appears to have gone from 0% to 100% without benefiting a single person. The cartoon version of that, I grew up on cartoons, is Snidely Whiplash, who has tied his victim down on the railroad tracks, and when the 5 o'clock train comes through, it's going to end that person's life. But now you develop a new diagnostic tool. Let's call it binoculars. And so you can make the diagnosis of train earlier, but it doesn't change the instant of impact. The third bias is length bias sampling, and that occurs because any screening test is more likely to pick up slow-growing cancers than it is to pick up fast-growing cancers. And the reason is right here. This is a cartoon of 2 different populations of cancers in the population. The top of the slide, the upper half of the slide, has short arrows. Those are the rapidly progressive cancers from the date of the start of the cancer to the onset of symptoms. And the lower half of the slide are the much slower-growing cancers that are depicted by long arrows. And so a screening test, the vertical dashed line, has a higher probability, this is a geometric certainty, a higher probability of picking up long arrows than it is short arrows. And so comparing the outcomes of the slow-growing, of the screen-detected cancers to the symptomatic cancers is unfair. You've built in a biologic bias in favor of the screening test. The extreme form of length bias sampling, that is the propensity of a screening test to pick up slow-growing tumors that are more indolent, is overdiagnosis. That is, you can actually pick up cancers that never would have caused medical problems in the first place had it not been for the screening test come along. This means a person might have harbored a cancer that is detectable by a new screening test, but they were not destined to ever be bothered by that cancer. they were destined to go on and live out their natural lifespan and die of something unrelated to cancer. And remember, cancer is, by its very nature, a disease of aging principally. And so if you have a screening test that is targeted to the elderly population, you can pick up a lot of cancers that were not destined to harm the person. Think prostate cancer, but many other cancers fit into that category as well that seem to occur in the elderly out of proportion to the young. So overdiagnosis is diagnosing cancer and, quote, curing the person, and I have that in quotes because the person didn't need to be cured in the first place. They were destined to die of a disease unrelated to cancer anyway. And so you think you have cured the person, but you've only detected them and given them treatment, and they go on to die of something unrelated. And if you never screened the person, you never would have known that you had cancer. So in essence, with overdiagnosis, you're curing people that didn't need to be cured at all. This was a theoretical construct that was raised in the early 1970s, but there were no clear examples until the early 1990s when the first very clear example of overdiagnosis was reported, and this was for neuroblastoma of childhood. Based on the types of observations that Dr. Bloodgood made, that is, you could pick up cancers you didn't know about, and based on the advent of a biochemical test that could be applied to the urine on wet diapers in infants that could pick up neuroblastoma, and based on the fact that neuroblastoma was and is a fearsome disease that was life-threatening to infants, widespread screening programs were started. And this is one that was started in Japan, and I refer to this as a national tragedy over there, which was a very large nationwide experiment. So all newborns in Japan, and in this case Saitama Prefecture, were screened shortly after birth for neuroblastoma with a simple urine test on wet diapers. And they were only screened when they were under the age of 1, and that's the left-hand side of the slide with both yellow bars and blue bars. They stopped screening for neuroblastoma in children after the age of 1, and that's the right-hand side. The yellow bars are screen-detected cases, and the blue bars are clinical cases that were diagnosed in spite of the screening. And you can see the timeline from 1981 to 1992 on the horizontal x-axis, and the incidence rate of all neuroblastomas in the prefecture on the vertical y-axis. And you can see, as you would expect, once you start applying the screening test, you would pick up a lot more neuroblastomas in these children. That's the yellow bars. But you would hope that if screening does what it's really supposed to do, that is, pull future cases out of the future and into the present, and you treat them, then cases of clinical cases, the symptomatic cases, the blue bars, would start to disappear with time. Hopefully over a decade they would go away, and they would certainly disappear in children after the age of 1, but that's not what happened at all. You can see the only thing that happened was there was a dramatic increase in screen-detected cases, but basically no change in the risk of getting the more life-threatening clinical cases. And the mortality rates didn't change, and the harms that were incurred were because of the additional treatment, which was, as I mentioned, major surgery and chemotherapy for these children. Now let's look at, that was the first clear case of overdiagnosis. And the natural history, by the way, and this harkens back to the data that was reported in the New York Times yesterday, the natural history of a screen-detected cancer, neuroblastoma, we now know in retrospect is to go away by itself or to differentiate into a benign tumor. And so and how did we gain the courage to even follow them without treatment? Well, it looked like that the clinical cases weren't going away, and so there was a new type of neuroblastoma that was being diagnosed by screening tests, and so the physicians started to follow their patients that were screen detected, not the clinical ones, without any treatment, and they saw that they either differentiated by themselves or went away completely. But that might be an exception because, after all, that's a disease of infancy, and that might not applied to the more common cancers in the general population that occur in adulthood and in the aged. Let's look at melanoma, which is a disease of adulthood. And this is the picture from the United States. Again, the timeline goes from 1986 to 2001. That's the horizontal x-axis. And the rate of diagnoses of melanoma is on the vertical y-axis. And you can see over the period from 1986 to 2001, there was a very rapid rise in the incidence, in the number of cases of melanoma in the United States. That's the top yellow line. But you can also see that almost all of that increase in the diagnosis of melanoma was early stage incidence, as you would expect with screening. And we do have a crude but commonly used screening test, and that is just total skin exam, or people looking at themselves in the mirrors and getting their partner to look at their back to look for suspicious lesions. And over the same period, there was almost exactly the same increase in rate of skin biopsies in the United States done by dermatologists and other surgeons. But as again you would expect, all of the increase was early stage incidence, whereas the incidence of late stage disease was about the same. It went up ever so slightly, but it was about the same. That's the blue bar at the bottom. And then finally, mortality was exactly the same, almost exactly the same. If anything, the rates of melanoma mortality have been increasing slightly. So again, just like with prostate cancer, you can tell by looking at it, mortality rate has been about the same or even increased a little bit, whereas the survival rate and the cure rate for melanoma has gone up dramatically. And breast cancer. This is evidence of overdiagnosis in a large Norwegian experience where 4 Norwegian counties staggered entry into screening. And so over the period 1991 to 1995, women were not getting screened except under opportunistic circumstances here and there. And that teal line on the bottom is the rates of breast cancer in the 4 Norwegian counties by age. This is not time, this is by age, from age 40 to 44 all the way up to women in their 70s. And you see that's the underlying base risk of diagnosis of breast cancer. Then after 1995, starting with the red line and then all the other colored lines, screening came on board. And you can see that there was a sudden, substantial increase in the risk of being diagnosed with breast cancer. And that risk dropped suddenly after women were no longer being screened, so that when women after age 65 stopped getting screened in the national program, their rates dropped down to the previous baseline. You would have hoped that if screening pulled cancers out of the future into the present, their rates would have dropped well below the baseline risk before screening started, but it didn't. It went right back to where it always has been. And so, again, there was an excess of diagnosis of breast cancer, which is hard to explain except by the diagnosis of breast cancers that you never would have known about had it not been for screening. So I've tried to walk you through 4 key cases of cancer where there is evidence of overdiagnosis: neuroblastoma, prostate cancer, breast cancer, and melanoma. And so I'm starting to conclude that overdiagnosis may actually be the rule rather than the exception whenever a screening test is involved. But can it occur with the most lethal and fast-growing cancers, lung cancer? We've accepted for a long time that at least some of the above cancers are slow-growing, but lung cancer has traditionally been considered one of the most virulent, fastest killers in all of oncology. So let's see if you can get overdiagnosis with lung cancer and its fearsome reputation. This is, and the answer is yes, I'm leading you down the path that I want you to go. This is a famous trial of lung cancer screening back in the early 1970s, in which smokers, male smokers, were randomly assigned to be screened by chest x-ray, plus a pooled sputum, or to a no screening arm. They were just told that they should get an annual chest x-ray, but they were given no reminders, so that was the control arm, the usual care arm. And compliance was good in the screened arm, and there was crossover, there was contamination. Some of the people did get screened in the control arm, but not enough to wash out the effect of overdiagnosis. So you can see, again, as expected, in the bottom portion of this trial, that in the screened arm, there was an excess of diagnoses over the first 6 years of the trial of cancers in the screened arm, 206 versus 150. And there was a large increase in the numbers of early stage surgically curable cancers, 99 versus 51. And the proportion of cases that were early stage went up substantially, 48% compared to 32%. And the proportion of people who could be resected went up substantially, 46% versus about 32%. And you doubled the number of curative operations. But the bad news from that slide is the incurable cases, stage 3, that can't be cured by and large by surgery, didn't change at all. The number of late-stage cancers was virtually the same in the screened arm versus the unscreened arm. And those are the ones that cause the deaths, really, or the rapid deaths in lung cancer. So let's look at what happened in terms of survival and then mortality in this population after about 20 years of follow-up. So you see the screened arm has a survival rate that is more than twice as good as the usual care arm. And these are two cured populations, flat survival curves over time. I mean, there's no change in risk of death over a long period of time, and you can see that the screened population had a far better survival rate. If we could reliably develop a therapy that was that good, we would consider it a major breakthrough. We unfortunately don't have one yet that would double cure rates, but nevertheless, the survival rate was substantially better, and the cure rate was substantially better. But remember, to the extent that overdiagnosis occurs, we're curing people that didn't need to be cured in the first place. So let's see what happens to the risk of death in those same two study arms. Here you get a far different picture. This is the accumulating number of deaths from lung cancer in each of the two arms. And you can see that, if anything, the screened arm had more cumulative deaths of lung cancer than the usual care arm. It's not statistically significant, but it's statistically a trend after all those years. The p-value was less than 0.1, although it's greater than 0.05 for those who follow. The actual p-value is 0.07. But nevertheless, there's no hint that the dramatically improved survival rate translated into a better mortality rate, or at least a lower risk of dying. Now we have even more sensitive tests because the chest X-ray is not all that sensitive. So let's see if we can dip even further into that iceberg of disease and find evidence of even more cancers. And the answer is yes. In Japan, where there is also a great deal of enthusiasm for screening, much like in the United States, they've even been screening people with spiral CT for lung cancer in people who never smoked. We generally in the United States restrict the screening to people who have smoked or are current smokers. But in Japan, they have been doing it for quite some time to never smokers. And you can compare. We know, without any shadow of a doubt, that the most powerful carcinogen, cancer-causing agent, in common use in the United States and in the rest of the world is tobacco, cigarettes. And we know that because the risk of getting lung cancer in a smoker versus a never smoker is in the order of 10, 20, 30, 40, or 50-fold. And so we would expect to see that same ratio with never smokers in this trial. That's not what happened at all. If you look through the 3 years of the study, you can see that the risk of being diagnosed with lung cancer was about the same in never smokers as it was in smokers. So again, we're detecting cancers probably that never would have been known unless they had been screening with spiral CT. So again, you would expect survival rates to go up. Mortality may or may not change depending on the worth of the test, the net worth of the test. So I want you to take away the important lesson that comparisons of survival, when a screening test is involved, are invalid if screening is involved. That's not true for therapeutic trials. Remember, in therapeutic trials, you randomly assign people all at the same stage of cancer into one arm or the other. And so you start the clock at the same time. So for therapeutic trials, as they're currently conducted, survival rates are, in essence, a reliable measure of what would happen in the risk of dying. That's not true when a screening test is involved, and you're starting the clock differently. And then finally, we've been talking about whether a screening test saves lives or not. There are net harms. Every screening test, just like every medical procedure, is associated with some form of harm. Here is a case in point for removing parts of lungs of smokers and former smokers who have been diagnosed with lung cancer. It is a morbid procedure. It's a major procedure, and some people will die of the procedure within 30 days. And these are average statistics in the United States. That is, death at 30 days after the operation for lung cancer. If you died on the 31st day, it didn't count as a death due to surgery, even if it was to surgery, or the 32nd day and so forth. And yet there could be deaths that occur after the 30th day because people who smoke have underlying heart disease, they have underlying lung disease, they may not tolerate having parts of their lung removed, they may not tolerate radiation to the remaining healthy lung, they could become pulmonary cripples, they can get pneumonia, they can die of a heart attack because of increased cardiac stress, because of lower ability to oxygenate their lungs and the rest of their tissues. But this is the 30-day mortality, and there is in our country, about a 5% 30-day mortality rate in people who had lobectomy, that is one lobe of their lung removed for lung cancer, and about a 15% 30-day mortality rate from pneumonectomy, that is removing the entire lung in a patient who has lung cancer. Since large volume hospitals have slightly lower rates of 30-day mortality than small volume hospitals, that's reflected along the bottom of the curve, along the bottom of the chart. The people, the hospitals that did the most operations had slightly lower 30-day mortalities, as you might expect. Likewise, another counterintuitive concept, you may be aware that about 10 years ago there was and is a raging debate over whether or not there's a net benefit to mammography in women in their 40s, and some organizations recommend for it, other organizations recommend against it in their 40s. Most organizations recommend strongly for mammography in women beyond age 50. But the debate went on, and some people said, well, even if it didn't save the lives of women in their 40s, at least it would spare women their breasts. But when you actually looked at the randomized controlled trials, that was not the case. And that's shown on this slide. It's a little hard to interpret, but nevertheless, this is the ratio. This slide is the data on this slide represent ratios of mastectomy rates between the mammography arm and the non-screened arm in these trials that reported the mastectomy rates. So that if there were more mastectomies in the screened arm than in the no screened arm, then the dots would be on this side of no effect. That is a ratio of 1. And if there were more mastectomies in the control arm compared to the mammography arm, you would see dots on this side. And as you can see, all of the dots are on the wrong side of that line. That is, each of the trials showed that more mastectomies, not fewer, were being done in the screening arms of these randomized controlled trials. And so that stands to reason as well because of the issue of the potential of overdiagnosis. That is, it is true and remains true that a lower proportion of diagnosed cases of breast cancer will undergo mastectomy if they've been diagnosed by mammography, but the total number of cases of cancer goes up because of the issue of increased cases of cancer associated with any screening test. And so overall, there was about a 20% increase, relative increase in mastectomies in the screening arms compared to the control arms. And that's why, and that's only detectable through a randomized controlled trial. And so I'll point out that there is simply no serious scientific alternative to the generation of large-scale randomized evidence. Unfortunately, in the case of screening, it is almost impossible to determine definitively the benefit, whether a screening test has a net benefit. So we have to resort to large, unfortunately expensive, but definitive randomized controlled trials where we evenly divide patients, people, not patients, participants, to be screened or not. We randomly assign them to be screened or not, so we create two identical populations, and the only difference between the two populations is whether they get screened or not. And then we count the number of deaths due to the target cancer, and So if it's an effective test, we expect to see fewer deaths in the screening arm than in the non-screened arm. As I mentioned, that's exactly what didn't happen in the early lung cancer screening trials that I showed you from Mayo. This is the schema of the PLCO trial that I've mentioned and John mentioned. Again, PLCO stands for prostate, lung, colorectal, and ovarian cancer, in which about 155,000 people, ages 55 to 74, were randomly assigned to be screened or to the control arm of usual care. And although we haven't reported the ultimate results, it started in 1993 and is still ongoing 15 years later. The Independent Data and Safety Monitoring Board tell us that the hypotheses remain intact and to continue the follow-up, which means that, at least in the case of prostate cancer, it's been 15 years and there hasn't been a decrease in prostate cancer mortality to our knowledge in the trial. And so that means that the downturn in mortality that I showed you nationwide in the SEER database is not very likely to, because it was a very rapid downturn, is not very likely to be attributed to screening. It's more likely to be attributed to more effective therapy. But we have the opportunity in this study to look at another harm associated with screening tests, and that is false positives. Most of this talk I've been focusing on overdiagnosis. That is, making a diagnosis of cancer that the pathologist calls cancer, but which never would have gone on to harm the patient. False positives is quite the opposite. That is an abnormal screening test when the person doesn't have cancer. But nevertheless, having a false positive test for cancer is very frightening to anyone. And so if it happens frequently, you are frequently alarming people unnecessarily. And this is data from the PLCO trial, which Jennifer Crosswell in my office and I have analyzed and recently published in the medical literature. You can see that for women, the blue diamonds, and men, the yellow squares, there's a very rapid increase in cumulative rates of false positive tests. 4 tests occur on the very first day, so that you can see at the end of one day of screening, men have about a 35% chance of a false positive cancer test, and women have about a 25% chance of a false positive screening test. At the end of 14 tests, which is 3 rounds, just 3 years of screening, men had nearly a 60% chance of a false positive test, and women had about a 50% chance of a false positive test. So it's a very common occurrence, much more common than overdiagnosis, obviously. And so I'm going to start to wind down and leave you with some quotes. Sir Muir-Gray said, "All screening programs do harm. Some do good as well. And of these, some do more good than harm at a reasonable cost." And we haven't even talked about a cost. We're starting to learn that cost counts these days. We're in the midst of a financial economic meltdown, so we can't afford the luxury of useless tests out there, and we certainly can't afford the luxury of useless tests that have a net harm. So I think it's important to be very, very careful before we embrace screening tests. Otherwise, you're left in the following situation. The cowboy that shot another one dead, and now starts to ask him who wrote the Odyssey and the Iliad and so forth. And the third cowboy says, you can't shoot first and ask questions later. And that's the problem with screening. It probably happened to an extent with prostate cancer screening. If you shoot first, it's very, very difficult to answer questions later because most people have already made up their mind, even in the medical community. And with that, I'll leave you with a favorite quote of Albert Einstein in praise of Galileo for a good reason, I think. And he basically said that intuition and logic counts for nothing. You need to carefully look at the science and try to dissect the truth. And that I'll stop and see if there are any questions.
So I'll start with the question.
All right.
I'll use your mic.
Let me see if I can see what you're saying. Oh, okay.
So, in your family, do you advocate screening for breast cancer, prostate cancer, colon cancer, or not? And if you do, or your friends do, and something comes up positive, what do you tell them to do?
Yeah. So the only person I have to tell in my family about prostate cancer is me, and the only person I can talk to about breast cancer screening is my wife, and usually I don't tell her what to do. Almost always the information flow is in the other direction. So I don't tell her that she should or shouldn't get screened, but I make her aware, as I'm aware in the case of prostate cancer, of what we know about the benefits and harms. Now let me tell you about me in particular, and that is I've personally, until the results of the PLCO trial are out, I've done everything in my power to avoid getting a PSA test, and the reason is the data that I've already shown. That attempt, although valiant, was unsuccessful. Because, as you might imagine, you know very well, by the way, when you're getting a digital rectal exam, and of course I know when to avoid that or not, or how to avoid that. But a PSA test is something you may not even know you're having, as occurred in my case. So when you go in for a blood sugar test or a cholesterol or whatever, it can be done because some physicians' offices are simply putting the routine PSA into the panel. And that's sort of the opposite of informed decision-making. So I had a PSA test once, to my knowledge, in my life. Otherwise, I do my darndest not to get it. Now, my wife she's well beyond the age of 50, as am I. I'm actually more beyond the age of 50 than she is. So she gets it. But she has borne the consequences too. She's had several biopsies and false positives and so forth. But nevertheless, I think there's a common agreement out there amongst the organizations that there's likely to be a net benefit for women over 50. Most of the debate is for women under 50. I don't know if that answers your question.
Think Forward. Think Research Channel.